So we tried to do anti-grade wiring, but every time the wire went in through the bridging collaterals. So we had to do it through the retrograde. The only surviving vessel is like a RCA, which has a distal good-sized RCA. So we went through the distal RCA, and with the help of this distal wire, which was at the distal cap, we did anti-grade wiring, like a kissing wire technique. And what happened through the LCX collaterals, we have wired it, and the wire went up to the distal cap. And then with the kissing wire technique, we have wired anti-gradely and did an IVO study also. During the IVO study, the patient crashed. We developed asystolic arrest. We did a CPR, and temporary was implanted, and then we put a IABP. You can see the balloon on, and with the help of IABP support, we completed the procedure. That is, the stenting was done. You can see a good sizable RCA with a good outflow here. So what I understood from the other case example, if you do a precarious with severe hemodynamic compromise without a IABP support, you can see the mean pressure will come down within a few minutes in some of the patients because of the prolonged ischemia or contrast load and other adverse hemodynamic factors. So ideally these patients should be protected with the Impella, though it is not available, at least with ECMO. So when we support these patients, you can see the yellow bar which shows the mean pressure is well maintained, and we can complete the procedure safely with the help of this device. The second case is again a young guy who, taking the experience from the previous patient, he has a ischemic cardiomyopathy but preserved wall thickness. That made us to think whether this patient has a viable myocardium. He did a PET scan that showed viability in both LAD as well as RCA. And we did an angiography as well as right heart cath. The right heart cath showed an increased PA pressure, and the LVDP is also increased. Then we went for elective ECMO because during the ICU stay he developed recurrent VT. That only made us to, because IABP also cannot help in recurrent VT, so that made us to go for a higher hemodynamic support. So we prophylactically inserted ECMO into the femoral artery with the 18 French and vein with the 21 French. The one, as you rightly noted, the one good thing in surgical cut down, we can do a distal limb perfusion, whereas in perclose and other things, we can't do that. So if you want to prolong the ECMO, this is the best option. And we only primed the circuit. We didn't make the circulation on. So in case of crash, we can do it within 2 to 4 minutes. So this is the cut down, and this diagram is shown that ECMO is a very small console, which we can keep it in any small cath labs, and this is the LAD, which is totally occluded after a large diagonal. And the LAD is diffusely diseased, and the middle LAD is occluded, and there are some collaterals which is supplying the occluded RCA also. It has a double occlusion. And with the anti-grade wiring, with the Gaia 1 wire, I could, it is not taking much challenge for me. I could wire the lesion and stented the vessel also. But even after the mid LAD stenting, the distal LAD is diffusely diseased. Then we did the RCA stenting. RCA has a very short, very discrete total occlusion, though it looks like a functional occlusion. And I could wire anti-gradely with the help of fine cross and only with the XTR through the microchannels. And with the body wire, the RCA was reconstructed. The RCA is a very good sized vessel. You can see the cannula of the ECMO circuit, which is in the right atrium, which is almost 24 French. And this patient was extubated and weaned from ECMO on table itself, because it was used only as a bailout one. And after that, we put this patient on IABP also for 1 more day. So we did an arteriotomy closure and did a check angiography also of the vessel. The distal limb vessels were perfusing well. This is just to show, and some of the patients who carries a very high risk factors like very severe LV dysfunction, when the PA pressure is high, when there is significant MR, and there is no other option, surgically turned down. These patients, we need to better support with a support device, at least during the procedure, so that we can offer a complete revascularization. Thank you, sir.
Thank you. I think we'll move on to the next talk by Dr. Srinivas Reddy. Is there? Hi. Dr. Srinivas Reddy will speak on distal vessel remodeling following CTO PCI. Srinivas.
Very good evening to everyone. And first of all, I would like to thank the organizer for inviting me to give this talk. And my talk would be on distal vessel remodeling following CTO PCI. So this distal vessel remodeling following CTO successful revascularization is an important concept. First of all, I'd like to show a case history. It's a 52-year-old male patient who is a diabetic and hypertensive for last 8 to 10 years. He presented with antival MI. In 2010, he went and successful PCI to LAD, following which he was asymptomatic for the next 5 years, and he presented with chronic stable angina for last 6 months when he presented to me. So he had a TMT positive and ejection fraction of 50%. So that was the first initial angiogram. So LAD stents were patent, and you could see there's retrograde filling of grade 1 collaterals to RCA, and RCA was mid RCA CTO. So after discussion with the patient, we went ahead to completely revascularize this patient. AL16 guiding catheter was taken, then after a fine cross micro catheter, field X-ray attempted with field X-ray, it failed, then went with Gaia's second wire, and that crossed. So after 1.25 and 6 mm splinter balloon inflation and 2.15 balloon inflation, so you can see there's a diffuse disease extending from proximal to the distal RCA entire segment. So we did a stenting from the proximal to the segment just proximal to this RCA. At that time we didn't have the longer stent, so I had to deploy the number of stents per more. So the post dilatation was done with high pressure NC splinter balloon 3 into 9 mm balloon, and followed by proximal segment 3.5 into 9 mm balloons. So that's the final result. You can see the stent was segmented this RV branch, the second RV branch, small RV branch. You could say there's a disease seen extending from the distal to the stent, proximal to the bifurcation, and the PLV branch was diffusely diseased, and there's a mild plaque in the PDA branch. So he also underwent a PCI to L6 also. And this is the coronary angiogram follow-up after 2.5 years. You can see all the LAD stents were patent, L6 stents were patent. And that's the RCA. Now if you look at closely the angiography which was performed in 2015 and 2018, you can see this blue dark line is the distal stent edge, and there was a plaque initially in the just distal to the stent, and there was mild stenosis proximal to the bifurcation, and the mild disease in the ostial to proximal PDA, and the PLV branches were diffusely diseased. And corresponding segments, you can see there is a luminal enlargement of the just distal to the segment, and this disease was mildly either there was no change, and there's a significant improvement of the PLV branches. There's increase in the diameter of vessel and increase in the flow. So this gives up the concept to understand what is happening to the distal to the vessel following a successful PCI. So what's the pathophysiology of this distal segments in CTO? So there is a decreased nitric oxide and increased endothelin, which is a potential vasoconstrictor, and which leads to proliferation of non-contractile smooth muscle cells into intima, leading to structural alteration of the extracellular matrix, vasoconstriction and tissue reorganization, leading to inward arterial remodeling and increased stenosis. So some studies were conducted to look at what's happening to the endothelial function and the smooth muscle function. In a small number of patients, of 19 patients, luminal diameter was assessed by coronary angiography and coronary blood flow at the level of epicardial coronary artery treated distal to the CTO prior to administration of acetylcholine, adenosine and NTG, and after that with respect to the collaterals. So overall, acetylcholine adenosine caused coronary artery vasoconstriction, whereas NTG failed to induce vasodilatation. But coronary blood flow significantly decreased with acetylcholine, significantly increased with NTG, but no change with adenosine. So the patient with CC2 collaterals had less vasoconstrict response and reduction of coronary blood flow after acetylcholine, and had a better vasomotor response to NTG than patient with CC1 collaterals. So this study suggests that there is significant endothelial and smooth muscle dysfunction present in the distal segment after successful reconnaissance of CTO, which is more seen after when there is a low grading of collateral circulation to the vessel. So Dr. Galassi et al. Looked at the vasomotor function after successful revascularization CTO in 100 patients. They looked at the coronary artery diameter after giving NTG at the level of 5 mm distal to the stented segment, 20 mm, 35 mm. And in a subgroup of 14 patients, they also looked at the endothelial function with incremental atrial pacing and intracoronary NTG. In others, 13 patients, they looked at the IVAS. Follow-up angiography was done in 9 to 12 months. So the vessel diameter significantly increased on follow-up after the initial angiogram. The at baseline distal segment failed to respond to the both endothelial dependent and independent stimuli. On follow-up, atrial pacing induced vasoconstriction, whereas NTG administration resulted in significant vasodilatation. But intracoronary ultrasound failed to show any changes in the cross-sectional area of the distal segment on angiography. So they proposed that there could be hibernation of the vascular wall at the distal coronary segment that failed to respond to this stimuli. So distal vessel diameter but tend to increase over time even in the absence of posterior remodeling and in spite of persistent endothelial dysfunction. This severe impairment of vasomotor tone after CTO reopening suggests that intracoronary ultrasound is of prime importance in doing the selection of the stent size. So what are the mechanisms which they proposed was there is impaired endothelial dependent or independent vasomotion after CTO PCA, there is intense vasoconstriction, there is a posterior remodeling or combination of both. So this leads to the increase in the lumen area and vessel wall size distal to the post-PCA CTO on follow-up. So the other study which looked, it was IVAS-based study from the Korea which looked to look at the vascular remodeling which occurs distal to the CTO PCA because the increase in blood flow caused alteration in the shear stress in the distal vessels. So 58 consecutive patients were enrolled. IVAS was done at initial and after 6-month follow-up. And they showed that minimal lumen diameter, mean elastic membrane diameter and the lumen area increased significantly, and there was also increase in the LV ejection fraction on LV injection. So of which around close to 69% of the patients showed luminal area increase, and patient had increase in the luminal diameter and increase in the incomplete stent apposition rates. The predictors of improvement in distal vessel flow was initial poor collateral flow, the longer the duration of CTO and the statin use. So this suggests that while doing a PCA, we should understand that the vessel might grow in future, and you should think in the terms and deploy stent which is adequate to the vessel. And the other study which looked in 91 patients did a coronary angiography at follow-up and at 12 to 18 months. 13 patients underwent IVAS, and this also showed that there is an increase in minimal lumen diameter, mean lumen diameter, maximum lumen diameter at 1 year of follow-up. The lumen enlargement was greater in patient where there is non-restenotic lesion, small lumen area at baseline, or lower LDL therapy. And on IVAS, the lumen volume was increased, vessel volume was increased, and the plaque volume tend to decrease. The smaller lumen at baseline was related to greater lumen enlargement. To conclude from this study, segments distal to the recanalized CTO showed a notable lumen and vessel enlargement with a trend toward mild plaque regression, lower LD levels, increased lumen enlargement. So my take-home message would be that following a CTO PCA on follow-up, there exists some endothelial and smooth muscle dysfunction in the distal segments. There is impaired endothelium dependent and independent vasomotion. There will be positive remodeling. So during selection of stent, I think imaging guidance will help us, and to limit these stents only to the CTO segment rather than stenting the entire artery, and starting therapy will help in distal vessel remodeling. Thank you for it.
Thank you. Srinivas, very, very eloquent. We don't have questions for you. Excellent. We'll try to switch to Yamane. Case is there? Live there? Can you switch live there?
So can you see the angel?
No, we can't see.
Yeah, now we can.
Yeah.
I've flashed already, just now.
The angel is on the screen?
Yes. It is on the screen.
After you left, that here, right, a retrograde guide wire actually crossed to the distal LAD, and we succeeded in returning to the more proximal portion, like this, and after that, everybody can imagine that the integrated retrograde looks like very close and retrograde wire into the septal branch. And we exchanged to this guide wire, Sion black, but which was not behaves very well in terms of reverse card, probably good, but I'm thinking of a little bit different things. So I exchanged the retrograde guide wire to the Gynex 2, which failed to get into the antegrade corsair lumen. So we decided to do the some reverse card over the this is just a try to the rendezvous inside of the LAD. And then we do the 1.5 millimeter balloon inflation here, antegrade, and which let the retrograde wire into the proximal portion into the guide catheter here. And of course, after that, it's best used for the IVUS confirmation that the left main and LAD is inside of the true lumen. And we confirm that the IVUS. And actually, after that, we try to do the, this is the IVUS, and then we do the rendezvous, because in this case, we try to remove the retrograde system as soon as possible. So we just do the inside of the guide rendezvous, which succeeded here, and retrograde Gynex 2 and antegrade corsair just jump in. So we advance the antegrade corsair and pull the retrograde wire here and advance the antegrade Sion wire here, and which get it to the distal true lumen. And we just confirm in the two different projection in the position of the antegrade guide wire. So could you show us the IVUS, the first run? Because our concern is not only the in-stent, but the distal vessel is very much small or rich plaque, and actually which turned out to be the very small. This is a proximal segment. Next run. This shows just we are in the true lumen over the retrograde wire, and this is run. And this is a distal LAD, which shows very much remodeled. Less than 2 millimeter vessel. So far we cannot do anything on this except for the drug-eluting balloon we use. So we just place the antegrade wire and pull back, and the retrograde route is confirmed with a selective injection, which is of course okay for the septal route. And we use a 2O balloon inflation, and then we do the IVUS, as you already seen. So after that, we decided to use 3O balloon for the proximal dilation a little bit more, because the stented portion was partially dilated here. So after that, we use a drug-eluting balloon here, 30 millimeter, 2.5 millimeter for the 30 seconds. And more proximal portion, we use 2.5 millimeter, 38 millimeter drug-eluting stent. So we confirm that the proximal portion and distal landing zone is beyond the previous stent. And after a stent deployment, we use 3O to the distal portion, not beyond the distal stent. And the proximal portion with the 3.25 millimeter NC balloon. And this is the end outcome. And although we see the tapering stenosis in the distal portion, but this is already dilated with a 2.5 dB, and we check with proximal dilation as well, and we additional balloon dilation 3.25, as I said. And this is a final shot with the wire and a lot of side branches preserved, and without side branch, without guide wire. And somebody may be concerned about the distal vessel, but distal vessel is
time. Maybe you can have a check angio or
remodeling of the distal part is going to improve, yeah.
Good, sir. Thank you very much for your...
Yeah, thank you very much. I really appreciate all the people
Have a nice
supporting me, and especially the my co-operator here. And probably we are very happy with the every outcome for the patient. Thank you very much.
Thank you so much.
Thank you.
Thank you very much.
Ganesh,
Yeah, I'm here.
you can start your presentation, please.
Okay, so long-term results of full metal jacket and what's the follow-up data on it. Stenting of long segment lesions covering more than 60 millimeters is the definition for full metal jacket. With complexity of the cases that we are doing, more and more metal jackets are being made all over the centers, and with more and more complex cases being refused for CABG, we do create a lot of metal jackets. So what's the data? So a few examples, and then I go to the data. 57 years old male, 2010, triple vessel disease, high-grade stenosis in the RCA. The right side thing shows acute closure, wire-induced acute closure because of dissection. Patient crashed, and we had to really use a star technique to re-enter into the true lumen, but you see on the right side, the entire right coronary artery got dissected because of the star technique, resulting into putting 3 long stents, and this is the result where we lost the PD and you see the PLV. But at the end of 2 years, we got the PD back, and this is the result. So another case, 2012, 60 years old lady, unstable angina, triple vessel disease, RCA CTO. When the RCA is opened, you see it's a diffuse disease, right, going up to the distal right coronary artery into the PD. So what do you do in such cases? Focal versus metal jacket. We ended up putting 2 long stents, and this is how it looked at the end of the case, not knowing how the long-term results would be. I angioed her after 5 years. This was in 2017, that was in 2012, and it looks quite good. Another case, full metal jacket versus focal stenting for the sake of discussion. RCA 2004, this particular patient underwent a focal stenting in the right coronary artery, and now he comes with a CTO. We open up the instant CTO, and after opening, you end up getting this type of results. I mean, what do? You make full metal jackets. So this is an example. I said you're forced to make full metal jackets in such cases. Versus focal stenting. Okay, mid RCA and distal RCA, ulcerated plaque, you do focal stentings, leave the area between the 2 stents, and he comes back with this. So you can get all types of results. I mean, so what is the data saying? Long-term, longer stent coverage, we are all concerned about restenosis, loss of side branches, vasomotion, we all know that. And so what's the data? Now, few papers I'll just run through in the next 3 to 4 minutes. Comparison of midterm clinical outcomes between complete full metal jacket strategy versus incomplete metal jacket. This was published in last year in 2017. 68 patients with full metal jacket, 53 with incomplete metal jacket. 30% of these cases were CTOs, and you see the midterm MACE was significantly less in full metal jacket compared to incomplete metal jacket, especially more favorable in diffuse right coronary lesions in this paper. Another paper published in 2016 in the International Journal of Cardiology, 120 patients followed up for a period of 41 months plus minus 21 months, 30% again CTO cases, and you see 11% had at least one MACE, while a very low number of cases had a TVR. Another paper, 2009, by the Colombo's lab, 658 patients received full metal jacket in 617 patients. Again, more than 30% of the patients were CTOs. The MI, stent thrombosis, and cardiac mortality rates were quite low and were comparable in both the CTO group and the non-CTO group. The MACE was comparable. So long CTO lesions may not necessarily lead to higher rates of restenosis when compared with very long non-occlusive lesions. This is what this paper tells us. Another paper, 300 patients, native coronary artery disease, underwent PCI, median duration of 75 months in this case, which showed, this is what it showed. I mean, but the conclusion in this paper was that perhaps newer generation stents would lead to further reduction of TLR and TVR, which was close to 6% and 30%. One more paper, 2013, PCI using full metal jacket was quite reasonably efficacious, but was associated with increased stent thrombosis in this paper. However, there was no difference in the MACE between the CTO and the non-CTO group. 77 symptomatic patients treated with everolimus eluting stents. Almost 40% were CTOs in this paper. No difference again between the CTO and the non-CTO group at the end of 1 year. So what do all these papers and what is the take home? Like DS have, as we know with the newer DS, we have very low rates of restenosis compared to the BMS. Stent strut thickness of the newer stents of less 80 or less than 80 microns gives very favorable results. Perhaps in the future when BBS will come back, we'll address the issue of vasomotion, and of course better delivery of platforms makes it easy to do the full metal jackets. Full metal jackets is no more a consequence of a complication, but rather has become a routine strategy for the management of long diffuse lesions in some of the examples I showed. No difference in CTO versus non-CTO PCI when it comes to full metal jackets. And of course, using imaging tools like IVUS will further improve the results of full metal jackets. Thank you.
Ganesh, very nice. And would you propose to change the definition from 60 millimeter to 75 or 890? That would be more meaningful now. Yeah, because 60 would have been very routine now. A lot of people are doing 60 millimeter plus in routine, but it's very...
Can I ask one question?
Sure.
Do you think that IVUS guidance would improve the outcome further?
Yes, that's what my take-home message was. Like many of these papers were
These are without IVUS guidance. Most of the papers are without IVUS guidance.
Yeah.
CTO cases are, I think, less.
Right.
That's very good presentation.
Yeah. Thank you.
Thank you, Ganesh.
I don't know. I don't know. I mean, minimal overlap, of course, but you don't have a control on the overlap. There is no subgroup study of really looking into the overlap. But actually it doesn't matter.
Yeah. Okay. Alfred Gallus is not here now, I think. We'll move on to the other one, the tips and tricks of crossing. Is there?
Alfred, you are ready or you want to come or come later? At the end.
Yeah. Is Dr. Ashui Asakura is there? Tips and tricks of crossing angulated and COX-2 channels. Dr. Asakura.
Thank you, Chairman. It's my great pleasure to be here. Today, I would like to talk about this theme. In terms of wire selection, in order to negotiate retrograde channel, in this left side septal channel is very straight. Most of the time, we use Sion blue, and SO03. However, in contrast, right side septal channel is very tortuous. Most of the time, we start with an SO03. SO03 is a very unique catheter. Tip load is 0.3 gram, very soft wire. I will show you the case. In the septal channel, I tried to negotiate using Sion. However, I failed because this septal channel has strong bending at this portion. So I used SO03. This wire easily negotiate this bending. This case is RCA CTO. As you can see, LED was connected to the distal RCA. So this apical channel is very tortuous. And this LED had strong severe stenosis. So before the channel crossing, I treated this LED stenosis with stent. And then I tried to negotiate this apical channel using Corsair. I gradually advanced SO03. At the time, point is just rotate. We should never push this wire forcefully. And finally, I push across the catheter a little bit, and then I just rotate the SO03. This wire nicely pass through the apical channel like this. So we should be patient in this kind of procedure. In this case, RCA occlusion and very tortuous RV branch provided good collateral flow. This is aerial view. At the time, I used ClUB catheter. This catheter has a relatively larger lumen compared with Corsair, so tip injection is easy. At the time, push force is relatively remaining, but I just rotate this wire. Like this. But SO03, tip of the SO03 is very soft. So sometimes this wire cannot negotiate the tortuous channel. So next step is fill the XTR and Sion black. XTR has a polymer jacket and taper tip wire, as you know. And Sion black is 0.014 inch wire, not tapered, but polymer jacket wire. In this RV branch, I tried to negotiate this channel using CTO03. However, this wire was not able to cross this channel. So I moved to the filter XTR. At the time, we often create a very, very small acute curve at the tip of the XTR. And we can negotiate this RB branch. But if we use filter XTR, so 03 filter XTR and Xeon black, we sometimes fail. In this patient, I try to use this AC channel. But this channel is very, very tortuous. And finally, I failed to use this channel. Most of the time, the reason of failure is side branch. If the side branch is located at the top of the bend, the wire easily goes into the side branch. And also, when the channel is not straightened, wire could not advance anymore. So these two factors is very important. This is a summary. So 03 is the first choice for tortuous channels, and we should not push the wire forcefully. Wire manipulation should be gentle, and we should be patient. XCR and Xeon black are helpful in limited situation, but we should know the risk of channel damage. Thank you very much for your attention.
Thank you. Just as a small advice, if you have a distal damage, perforation of the epicardial collaterals, what is your general management for that?
If the CTO segment is successfully opened, we can do the hemostasis from both sides. But before the opening of CTO, it's a very serious complication.
Thank you.
Thank you. Next presenter is Kenya Nasu. Nasu is there? No.
Yeah, he's there.
Oh, nice to see you. We had a wonderful time in Toyasi.
The ipsilateral collateral channel for the retrograde approach.
Thank you very much, Dr. Dash. And good evening, ladies and gentlemen. I'm already tired. So today is one of the most hardest days in the half years. It took 5 hours to recognize the RCC long CDU. So my topic is the ipsilateral collateral channel for retrograde approach. Oh, okay. No.
I think these guys should have training in Japan, your center, how to arrange these things. We are still not able to overcome these problems.